Hi, my name is Jeremy Harris. I am a DPT student at the University of Pittsburgh, here to talk to you today about subacromial impingement. Relative to subacromial impingement, we must talk about the subacromial space. Subacromial space is formed superiorly by the acromioclavicular joint and inferiorly by the humeral head. There's quite a bit going on within that space. Some important ligamentous structures include the coracoacromial ligament and the acromioclavicular joint. Some soft tissues that are important include the subacromial bursa and supraspinatus tendon, as well as the long head of the biceps brachii. There are a number of those same structures above that will contribute to the development of impingement. Two classifications have been created. In primary impingement, our patients have pain from a bony abnormality, such as a closing in the space. But in secondary impingement, the issue can be due to instability, inflammation, or improper glenohumeral positioning. Some of these things are things that we can treat as physical therapists in the clinic. Commonly, your patient will report a gradual onset of pain. Pain will surface with repetitive movements, as well as overhead, across the body, or behind the back, in adduction, internal rotation, and flexion. Patient will also report of pain in the anterior lateral aspect of their shoulder, and may also report discomfort with sleep. It is important to note that the diagnosis of subacromial impingement is often a diagnosis of exclusion. So while you're evaluating for impingement, you would also subsequently want to evaluate for rotator cuff tear, bursitis, anterior shoulder instability, just to name a few. Some of those can be teased out or changed up based on their presentation with glenohumeral range of motion, scapular range of motion, capsular tightness, or weakness or presence of pain with manual muscle test. When looking at subacromial impingement patients, we want to look at three specific tests of diagnosis. Those include the Hawkins-Kennedy test and position, the painful arc test, and the infraspinatus muscle test, all of which should yield positive results if subacromial impingement is suspected. We will now take a look at physical therapy management for the patient with subacromial impingement. If you suspect involvement of soft tissue structures of the subacromial space in the diagnosis of subacromial impingement, initial prescription may involve stretching of some chronically tight tissues. This could include stretches for the pectoralis major, such as the doorway stretch, mobilization of soft tissue for thoracic mobility, as well as active assisted cane or towel stretches in order to promote new movement. It is very common to find the correlation between subacromial impingement, either weakness of the rotator cuff musculature or scapular dyskinesis. So, this can result in poor motor control or function of the rotator cuff musculature. So, we have to begin with basic movements such as active assisted range of motion of the scapular musculature, as well as facilitating scapular movement. Some of these can include scapular protractions or active range of motion with upper tract relaxation. As we progress to the second phase, we can now begin strengthening the cuff musculature. This can include external rotation and internal rotation in different levels of abduction, as well as some of our exercises targeting the middle and lower trap. So that would be our Y and T exercises. Clinicians should be careful to watch for scapular substitution during these exercises, as excessive retraction or protraction can be indicative of poor control from this muscle group. So in phase 3, we now want to begin adding in some of our dynamic stability and sport-specific exercise. Obviously, this patient has established normal motion as well as adequate strength to prepare themselves for these exercises. Some of the common things you'll see are the body blade, as well as new sport-specific additions to our treatment program. In order to allow additional motion at this joint, depending on the types of motion that we are limited in and restricted in, physical therapists can direct their interventions to that area. So keeping along the line with scapular dyskinesis, or poor scapular movement, scapular mobilizations are commonly used. Glenohumeral joint glides and distractions are typically used in order to regain normal motion about the capsule as well as about the restricted area of the shoulder. Here we have some examples of manual therapy techniques directed at the glenohumeral joint. Please note at the bottom of the screen mobilizations with movement that are pictured. These are commonly used both to facilitate movement as well as to free up any restricted structures. Here we see targeting of the acromioclavicular, scapular, and glenohumeral areas of the joint. Commonly used in some of the techniques with subacromial impingement are mobilizations directed at the thoracic spine. So, pictured we have our cervical-thoracic junction mobilization as well as thoracic mobilization. Both general techniques are utilized. As with any of our manual therapy technique administration, we want to be mindful of some of the contraindications as well as potential red flags that could present with manual therapy techniques. We have some listed here, and important things to always keep in mind when putting your hands on patients. Much to the physical therapist's dismay, physical therapy intervention does not always work for our subacromial impingement patients. If that is the case, we can refer them to another type of medical management. Typically, if they're receiving this medical management, they will receive an MRI, which can help us differentiate between bursitis and subacromial impingement or other issues going on within the joint. These patients seeking new medical management may also be referred for surgical consult. Comparatively, we can talk about the subacromial decompression and the open arthroplasty as two main areas. Subacromial decompression carries more favorable results than the open arthroplasty. The post-operative complications there are much more limited in comparison. One of the other avenues of medical management that a patient can pursue is a corticosteroid injection. So corticosteroids have been found and are very well known in regards to providing short-term relief. However, at least in the case of subacromial impingement, long-term effects are variable, if not absent. When measuring our patient's progress in the clinic, it's important to utilize outcome measures that have been validated by research. One of these is the disabilities of the arm, shoulder, and hand, commonly referred to as the DASH. New research has found that a 40% change from the original score on the DASH will indicate positive change in our patients. Important to look at a percentage change rather than a raw score change. You can find our references below. A more complete list of our references is available on the bottom of our Wiki page. Thank you very much for your time.